So without further ado, I'm going to stop share for Victor to introduce our very first speaker.
Okay, hello. My name is Victor. I'm a consultant in sport and exercise medicine in Changi, and I'm the outgoing president for SMES. Okay, so without further ado, let me present the first speaker. She's Miss Fadzlynn. She's a clinical exercise physiologist at KKH, and she has been practicing there for about 5 years. And she holds a master's degree in clinical exercise physiology and is accredited both as an exercise physiologist and exercise scientist by Exercise and Sports Science Australia. So she currently works with patients from a wide range of medical backgrounds, and the individuals will include those with developmental disabilities and to women-related conditions as well. So today, the title that she'll be talking about will be Bridging Movement and Medicine and the CEP's role in managing health. So without further ado, I will let Fadzlynn take over the mic, the webinar.
Okay, good afternoon, everyone. Can you hear me?
Yes, loud and clear.
Can.
Can see your
Okay.
slides.
Can. All right, that's good. All right, thank you everyone for spending your Saturday with us for the exercise physiology series. It's great to see the growing interest in this field, and a big thanks to SMES for inviting me to share a little bit more about what clinical exercise physiologists do for our patients as well as in the community. So let's kick things off by defining who clinical exercise physiologists are. So to get a well-rounded definition, I turn to the three major exercise science and physiology organizations, ACSM, ESSA, as well as the Canadian Society of Exercise Physiology. I then asked ChatGPT to combine their insights into a clear and concise definition to give me. CEPs are health professionals that specializes in prescribing and delivering evidence-based exercise interventions for individuals with chronic diseases, complex medical conditions, or physical limitations. Using scientific principles, CEPs assess, design, implement, and monitor individualized programs to improve health outcomes, functional capacity, and quality of life. So very nice textbook definition, but it didn't really highlight everything else that we do outside of the clinical space. So I'll take you through the roles and responsibilities of a CEP in the coming slides. A brief look into the origins of our profession. Clinical exercise physiologists were first introduced in Singapore in 2007 as part of our sports medicine service, focusing on lifestyle interventions for children with obesity, neurodiverse needs, and movement disorders. With growing developments in the field of sports medicine and exercise science, this led to further expansion of the service to include programs for women and children with other chronic and complex medical conditions. In 2020, CEPs were recognized as allied health professionals within the SingHealth institution, and a career development pathway was also established. Not long after, we joined the SSMC faculty to become SSMC at KKH. Since then, we have continued in the line of using evidence-based physical activity and exercise recommendations to help our patients prevent or manage chronic or complex medical conditions. We also engage in research in child and maternal health, focusing on the effects of physical activity and exercise on overall health outcomes. And today, we are honored to be recognized by SMES as part of the sports medicine and sports science ecosystem in Singapore. So what's next for us? So you'll just have to wait and find out. So the roles and responsibilities of a CEP may differ from institutions and clinics. However, here at SSMC at KKH, we can categorize our work to four main arms, which are clinical, research and innovation, education, as well as community. And the next few slides, I'll go deeper into what we can do for each arm. Starting with clinical services we provide, we conduct clinical exercise testing for our patients, and this includes maximal and submaximal exercise tests. Some examples include the cardiopulmonary exercise testing, CPAT, exercise growth hormone stimulation tests, allergy exercise challenges, and muscular strength assessments. So conducting these tests are a main priority to us because any symptoms triggered during the exercise can help with identifying the specific cause or intensity, which is important when it comes to prescribing exercise for our patients. Following the exercise tests and assessments, we then develop and prescribe individualized exercise programs to help improve the health or fitness levels of our patients. And during these interventions, we also monitor their physiological response and make modifications when necessary. Another important service we provide is patient education and counseling, where we often use behavior change strategies such as motivational interviewing to deliver our sessions. So some pictures to illustrate the services. So this is our CPAD setup, and that is me conducting group physical activity counseling for our patients with gestational diabetes. And for this group counseling, the patients all have similar EDDs, so it's easier for us to provide exercise recommendations on how far along they are. And this is our inpatient exercise program for our eating disorder patients, which we conduct in collaboration with our adolescent medicine nurses and physicians. So I'll categorize the types of patients that we see based on ages, starting with our 4 to 9-year-olds. We work with patients with neurodiverse needs such as ASD and ADHD. We also have the weight management program for our obese kids or kids with Prader-Willi. We also have patients living with CP or trisomy 21 or developmental coordination disorders. And we also engage with the patients that have been admitted for social reasons. So they do get some physical activity whilst they are being admitted for a prolonged period of time. For our adolescents or older children, we see patients diagnosed with eating disorders, mood disorders, and type 2 diabetes. We have a sports optimization program for our youth athletes with recurring MSK issues or returning back to sport from injury. We also have the POWERS program for our pediatric oncology patients, where we help them to transition back to school and PE. And we also conduct the CPAD for our congenital heart disease patients that have been referred to us from our cardiology colleagues. As we are a women's and children's hospital, our male patients are then transitioned over to the adult centers such as SGH, SKH, or CGH. However, for our ladies aged 18 and over, we typically see patients with menstrual issues such as PCOS. We have a weight management program for those with obesity or are trying to conceive. We also help ladies manage their menopausal symptoms such as hot flashes and body aches. We see moms diagnosed with gestational diabetes, gynae onco and breast cancer survivors looking to improve their physical function and strength, as well as patients of older ages with osteoporosis, osteopenia, and sarcopenia. So while we exist as a multidisciplinary team, and it helps that we have access to our patients' broader treatment plans, allowing us to align our interventions seamlessly, we also do conduct interdisciplinary sessions or consults so that it saves the patients time from going to multiple different appointments. And this also ensures that the patients receive comprehensive support from all professionals involved in a timely manner. In the field of research, we are currently involved in a collaborative randomized control trial looking at the effectiveness of lifestyle interventions in preventing type 2 diabetes in Asian women with prior gestational diabetes. While this study is still ongoing, we have looked at the data that has been collected so far and recently put up our preliminary findings at the recent Asia Pacific Maternal and Child Health Conference. And through the data analysis of about 213 participants so far, we found that physical activity counseling by CEPs can enhance participation in moderate intensity physical activity postpartum by up to 3 months. In 2023, our colleagues also published a clinical audit on one of our exercise programs that we conduct for our obese pediatric patients. And based on the findings, we have made necessary improvements to the program to ensure better health outcomes for our patients. And last year, led by our physician, Dr. Benny Lu, we also evaluated the acceptability of an online resource in promoting healthier lifestyle behaviors in primary and secondary school-going kids. And the study supported the development of a dedicated online resource to assist in implementing healthy lifestyle behaviors in our school-going kids. We have also embarked on a few innovative projects to help improve our clinical workflows and services. So led by our CEP Alif, we developed the CARE report to help us optimize data processing and analysis for cardiopulmonary exercise testing services. We wanted to reduce the number of steps needed to generate a report and also minimize human error calculations, which could potentially impact diagnoses and patient outcomes. So what our script does for us is essentially helps us to scan the multiple different data sets produced by a single CPAD assessment, perform the calculations and normative data comparisons, generate slope graphs and visuals, and also provide us with a summary of the interpretations. Since adopting CARE report and using R programming to automate our data analysis, we have since observed an improved turnaround time by 60%. It used to take us about 5 hours to run the CPET, do the analysis, and write up the report, but now it takes us less than 2 hours. And this has enabled us to see more patients in a day, improving the waiting time for a CPET appointment by 87.5%. We have also made fewer manual calculation errors, and because we don't take as long to write up a report anymore, we can then redirect our focus to our other clinical tasks. And this project has the potential to be scaled or adopted by other disciplines that also deal with data-heavy work. We are also in the final stages of collaboration with SingHealth HQ and the NUHS School of Computing to develop a fitness program for adolescents with obesity facing low motivation and engagement in physical activities. So this project will look at integrating Apple Vision Pro's mixed reality technology with mindfulness practices and physical activity. And we are hoping that the virtual environment and engaging application can help improve the fitness levels in our users. While it is our responsibility to stay updated on the evolving evidence in exercise medicine, it's equally important for us to also educate our colleagues in the health, fitness, and community sectors about prescribing exercise to improve health of those who they work with. So within our hospital, we have been given opportunities to take part in resident teachings, grand rounds, academic rounds, and allied health webinar series. And we are also regularly invited to be part of the nursing CME series and internal conferences. We also collaborate with community partners to equip them with the necessary skills to deliver effective exercise programs. For instance, we developed a trainer-trainer program for the Children's Cancer Foundation, guiding their fitness instructors on exercise prescription for pediatric oncology beneficiaries. Previously, the team also worked with Singapore Sports Council to create a fundamental movement skills workshop for preschool teachers. And in 2023, we signed an MOU with ITE, which paved the way for collaborative community outreach events focused on exercise science, preventive health, and active living. And this partnership also provides ITE students with hands-on learning experiences through projects and events. And over the years, we have also hosted more than 100 students from institutions of higher learning for internships, clinical placements, observerships, and also industry final year projects. Lastly, as CEPs, we always try to promote physical activity and wellness through outreach programs that support healthy lifestyle across diverse populations. And last year, we were invited to the Viva Foundation Family Educational Day, where we interacted with cancer survivorship patients and family members and had the chance to conduct a short exercise workshop for them. We have also been graciously invited to the Diabetes Support Group Camp that happens twice yearly, which happens every 2 years, where we conduct educational activities for our type 1 diabetic patients and family members. And this camp is something that the team looks forward to every 2 years because it's usually held overseas. And the team is already preparing for the upcoming camp in June this year, which is going to be held in JB. Many years of collaboration with the Family Medicine Service also means that we get to host workshops for women's health and family events, usually held in the heartlands of Singapore. And we are also very grateful for the support of our ITE colleagues and students that help in the organizing and running of these events. In fact, 2 of our CEPs were over at Changi CME this morning for a health and wellness expo, and they will also be running a family-based exercise workshop next weekend. Last year, we were also invited to conduct a physical activity and exercise workshop for our Children's Cancer Foundation partners and their beneficiaries as part of their Family Fitness Fun Day. And community also means our fellow colleagues and patients at KKH, and every year we try to celebrate World Day for Physical Activity. So leading up to the 4th of April, we do organize exercise challenges for our staff, and on the day of World Day for Physical Activity, we set up interactive booths for our staff and visitors of KKH to learn about the importance of keeping physically fit or to even just win prizes and goodie bags. So the community events did not stop during COVID. We actually managed to pull off 2 virtual events in 2020 by getting creative. And this actually propelled us to create more online resources that are still being used by our patients and event goers in the community. So what's next for us? So some things to look forward to. Led by our physician, Dr. Benny, we have started another RCT to evaluate the effectiveness of telemedicine-based exercise program to help improve cardiorespiratory fitness in Asian pediatric population. We are also trying to expand our clinical services to include pediatric cardiac rehabilitation, since we are seeing a rise in the number of patients being referred for cardiopulmonary exercise testing. And we are only but a small team and a tiny fitness center here at KKH, but we do hope that with the increase in visibility of our profession and what we do, we will be able to expand our services to more areas in Singapore to address the growing needs of improving physical activity and health in our community. Last but not least, we will not be doing what we do in such a huge scale without the hard work of our pioneering exercise physiologists, our ex-colleagues, and also our students. And I would also like to thank all our community partners and colleagues from different departments for giving us the opportunities to collaborate with them, as they have also helped to push this profession forwards for us. And that is all I have for today. I cannot hear you, Victor.
Sorry, just needed to switch on my mic. So can I just find out, Fadzlynn, that you'll be staying for the Q&A later?
Yes, I will be.
Okay. So what I will do is I will roll on to the other speakers, and anybody who has questions and is dying to ask for one, you can type on the chat group first, and we shall see how we shall respond later. All right, because we are running a bit tight on time, but thanks to Fadzlynn, we have a bit of a leeway. Thank you. I will move on to the next speaker. Yeah, the next speaker is Dr. Eevon Chia. He's a consultant and a longevity strategist and an exercise physiologist as well. So she's a doctor of exercise science and is reasonably healthy and fit. Over the years, she has observed that those who started building their health banks earlier in life were able to navigate illnesses more positively, respond better to medical treatment, and bounce back to thrive in their daily lives. And with a solid understanding of science behind exercise, she has spent the last 20 years learning, experimenting, evaluating, and incorporating evidence-based health and fitness practices into her life. So today she'll be talking about the health from the lens of exercise physiology, the scope of practice, and case studies. Without further ado, Eevon, please take it away.
Thanks, Victor. And let me share my screen. I think it's shared already, so maybe a couple of thumbs up to let me know, or maybe just sing out if it's not the screen.
It's not full screen. It shows just your PowerPoint.
What about that?
I think
All
you
good?
need to share the full screen PowerPoint. It's still
Let me stop sharing and try it again. Entire screen, window, entire screen. That one. Share. How does that look?
Yep, we can see.
Okay, thank you.
Yep.
So I'll start rolling. And thank you, Victor and Joshua and the broader SMAS team for having us. We are so excited about being a special interest group within SMAS, and we look forward to the way ahead. I think Fadzlynn shared the roadmap towards what we can expect in the future, and that is what all of us are working collectively to. I think Fadzlynn shared a lot of a very broad scope of what exercise physiologists do, EPs do, and my presentation is going to be fairly narrow. The focus is on older adults, and I will also focus on the what to do and the how to do. So we transformed lives, and this became apparent to me even in my undergrad days, where I worked with master students and PhD students on their studies. And of course, the feedback that you get after 12 weeks of exercise training is that, "Oh, I've gone back to working on my boat. I'm no longer afraid of pushing my grocery trolley full of food up or down a ramp." So they got stronger, they got fitter. Fadzlynn shared about the diverse population, and what I noticed is that even within the older adult population, there is also a very diverse capacities. So we are talking about your fit older adult who is the masters athlete, and you also have your older adult who has suffered from chronic conditions for a very long time. Mhm. So this is kind of why I do what I do. And Atul Gawande says it the best to me. So we used to live for a while, and suddenly death comes upon us. That could be through pestilence, or it could be or it could be having a heart attack on a business trip, where when CPR or AED wasn't as popular as today. Then with medical progress, so we got good at patching things up. So we can sort of fix emphysema, we can fix your liver disease, we can fix um, a heart attack. So what you see is that it's still a gradual downhill, and ultimately we still die. And you can also see that there is a big dip in the health, but there's also long periods of recovery. But what is clear is that you never quite go back to the peak of health. So with more medical advancement, we patch up your osteoporosis, we fix your hypertension, we can replace joints, and that prolongs the journey towards death. In developed nations, we are talking about maybe anywhere between 12 to 20 years of living life with some level of disability. So at the start, maybe you have some disability, still manageable, and then towards the last 6 to 7 years, we might be facing severe disability, which means that you need help with changing clothes, you need help with movement, and you possibly also need help with communication. So what I'm going to tell you over the next few minutes is about the Active Living Longer, a program that I created to fit the needs of the older population. We targeted the over 50s. This was in Australia. And the reason why we targeted the over 50s was because funding was available. But in that time, and even today, there are programs that are geared towards the general population, and the older adults can still be somewhat left out. Not to mention that there's also some cultural differences in terms of what older adults today think that they should do for exercise. So we wanted a low cost program, and we did some assessments, and I will share with you what assessments we did, but I will not share the numbers with you because they actually trend pretty much in line with whatever assessments and studies that are out there. Pretty much, if you train, you will more than likely get stronger and fitter. So it was a community program, and it's to my mind, it's very scalable, and this is what we're going to talk about. So Fadzlynn shared with you a couple of really solid slides about how people work together and the professions work together. We also worked with other professionals in other industries. I'll just share two examples. So a physician, my personal physician, actually referred her patients to me to practice in the clinic together, the program Active Living Longer. And in the referral went back the other way as well. So because we taught our participants how to measure their own blood pressure, eventually some of them actually got fit enough to change their blood pressure profile. And we gave them this data, and they also included some of the data that they collected at home. And they brought this to their physician, where they made a joint decision whether to titrate the medication level. As an exercise scientist, as opposed to an exercise physiologist or a clinical exercise physiologist, I was not comfortable working with joint issues. So what I did was I collaborated with a clinical exercise physiology, and anyone who presented to me with an issue that I was not comfortable with, what I did was I then referred on to a clinical EP, and they would make the diagnosis, and then they would give me the report and make some suggestions. So together we work together for the patient's best interest. So in terms of exercise physiology, there's no running away from assessments, your intervention. And because we're all here together on a Saturday afternoon, I am quite sure that we're all pretty keen on the education aspect of things. So what is it that we actually did? Now, in terms of assessment, we'll start at the top quadrant here. So how long is a piece of string? There are so many tests out there. If you ask ChatGPT what's the best body composition, how to measure body composition, you'll get a whole list. So how long is a piece of string? So many tests out there. You have to decide what you want to do, why you want to do it, and essentially how much money you have to do it as well. We ran the program as cheaply as possible. Okay, in this case, maybe not the cheapest option, which is anthropometry, height and weight. We actually chose to do BIA. But of course, you can go crazy and you can do a DEXA scan every 6 months, every year. Same story with cardiovascular fitness. You can do a CPAT testing, VO2 max test. We chose to do a 6-minute walk test. And eventually, we actually found the setup of a 6-minute walk test rather clunky, and we moved towards a 2-minute step test. We also looked at balance. So in terms of balance and function, this was particularly relevant to older adults. There is actually quite a few. So we chose to do timed up and go. We did functional reach, we did tandem stand, we did one-legged stand. For those who are more competent, we actually even looked at eyes closed and uneven surfaces. So balance with your eyes closed and balance on an uneven surface. And finally, one of my favorite topics, so in terms of strength training, we looked at a hand grip dynamometry as well as a 30-second sit to stand. So there are lots of tests out there, and you need to pick what is best suits the situation. So there is some opinion, and I sort of lean that way in terms of what system should we train first. So when we talk about wanting to get fit, we can talk about what do you need when you want to get out of a chair. So you need to be strong enough to be able to get out of the chair. You need to be strong enough to stand. And what do you need after you get standing? You actually need a certain amount of balance or capacity to balance so that you can actually remain upright. Only after that can you walk across the room and walk outside to get your cardiovascular fitness. So in some way, the order of focus in terms of exercise physiology could be getting strong enough first, working on your balance if need be, and then working on your cardiovascular fitness. So the next slide is pretty much my representation of what getting stronger is like. When we are sick, I go to the doctor and say, I'm sick. And it would be really confusing if the doctor tells me, just take medicine. And sometimes in the community, this is what we get as EPs, yeah. So we say, I need to get fitter. And many times the response is, I'll just start exercising. And it's simply not as easy, right? So when you go to the doctor and they say, take some medication, you really want to ask the following questions, or actually the doctor prescribes the following instructions. So what kind of medication to take, how much to take, when are you taking it, should you take it with food or without food, are we taking it in the morning or the afternoon, and how long should we take the medication for. Likewise, with strength training, this picture or image or mind map is what summarizes what we can think, how we can think about in terms of strength training. So I'll just take you very quickly through it. We'll start from the center, so you can sort of see a person in the center. So we can talk about your body parts. You want to get your shoulders stronger, you want to get your legs stronger, core, and so on and so forth. More often than not, we want to go from large muscle groups to small muscle groups. In the same vein, we want to go from multi-joint to single joint exercises. We'll move over to the top right quadrant. So we want to, and this part here, It's really the part that I feel where exercise physiologists come in and where the practical aspect of our practice comes in. Quite a few of the terms on this picture, you can actually look it up. But with the few slides, that's where the hands-on practice comes in. So what does intensity feel like? How much load should you be carrying? How many repetitions should you be completing? In terms of volume, so intensity multiplied by sets. If you think about someone who pushes an Olympic bar, so 20 kilos, you bench press it, and you may do that for 10 times. So 20 kilos times 10 reps is 200 kilos. You take a rest, whether it's active, passive, or how long you want to rest for. And you do it again, you repeat the sets for maybe 3 times. Essentially, you worked your chest muscles have lifted or pushed 600 kilos. So 20 kilos times 10 repetitions times 3 sets, that's half a ton, almost the weight of a small car. So we move down types of muscle contractions, pretty much a no-brainer. And we also want to teach people about progression. So we want to teach them about how you can torture the same muscle groups with 2 exercises. We want to teach people that they can exercise different muscle group sets. So we're talking about dividing the body into your transverse plane or your coronal plane. So you work your chest muscles, then your back muscles, or you can work your shoulder muscles and your leg muscles. We talk about progressing from bilateral movements to unilateral movements. So dividing the body using the sagittal plane. Some of the people in the group actually managed to progress to power training, essentially lifting the same amount of weight or lifting less amount of weight, but being able to generate the force in a shorter amount of time. So I'll draw your attention to the top left of the picture. So strength training can be done in various body positions. For those who attended the gym, this whole program was run out of the gym. We took time to explain that machines are comfortable to work with. It is in a climate-controlled environment. But we also wanted to let them know that in time, we also would hope that they progress into bodyweight training so that they can do the exercises anywhere. In this population, quite often periodization actually means that they went for a holiday and didn't train, or they got sick or had a bout of illness and had to recover. It's very different from the periodization that we think of in the athlete population. And then on the bottom left here, we talk about the do's and don'ts of exercise. Again, very similar to the top right here. It's these do's and don'ts are best conveyed in person. So if an image like that doesn't work for you, we translated it into a checklist, and you can see it embodies the same principles. So chest to triceps, working your chest versus working your back, working your shoulders, then working your legs, and so on and so forth. We aim to teach the older adults a couple of tick off one of these boxes, 2 or 3, whatever they felt comfortable taking on board during each of the sessions that they turned up. So we incorporated this checklist into their training diary so that they could refer back to it. Over time, they became fairly independent. So one more slide about how we actually conducted the sessions. It looks really simple, and it is a simple concept. So people turned up at 8 o'clock, and we taught them how to collect their blood pressure. So we wanted them to start exercise only if they're well enough to do. And blood pressure was one of the measures that was relevant to this population. So they take their blood pressure at 8 o'clock, and they hook straight into the strength side of things. At 8:40, we gathered all of them and we conducted an EP-led balance segment. The 8 o'clock group, after the balance segment, would take again their post-exercise blood pressure, and then they would depart at 8:55 or 9 o'clock. A second group started at 8:30, and they would take their blood pressure, then go straight into the balance, and then for the next 40 minutes after that, they would do their strength exercises. So this way, it created a community So the gym was big enough to take in about 6 to 8 people very comfortably. It also allowed other people, students, university students, or just other paying guests to come and use the gym. So we did not have exclusive use of the gym, but we still managed to have 6 to 8 people per session. So your 8 a.m. group can interact with the 8:30 a.m. group. They actually share the balance segment, and your 8:30 a.m. group would interact with your 9 a.m. group. So 9:30 a.m. group, and then your 9:30 a.m. group would interact with your 10 a.m. group. So collectively, on every morning from 8 a.m. to 11 a.m., we delivered in the terminology, we call it the occasions of service. So from 8 a.m. to 11 a.m., we delivered approximately 25 to 30 occasions of service. We ran this program across 2 locations over 4 mornings. So in a week, we would have delivered 100 occasions of service. So, oh, sorry about that. Close that. We don't need to expand that. So in summary, we moved people from feeling unexercised. They might not be feeling poorly yet. A 50-year-old can still be fairly strong. Even your 60-year-olds and 70-year-olds can be fairly strong. We tried our best and we did succeed on many levels to move them from unexercised to vitality. And yes, so that comes to the end of my segment. I will be more than happy to connect and, of course, read your questions later on. And over back to you, Victor. Thank you.
Hi, Victor. Do you need to fix the mic again?
Okay, I think this will good. Yeah, there's some issue with my mic. And anyway, thank you, Eevon, for the presentation. Kind of nice to know what the private world is doing to help people to move. All right, so we will move on to our next segment. Our third speaker will be Dr. Goh Jorming. He's a research assistant professor in NUS, and he's the head clinical sciences of the healthy longevity. Uh, no, he's the head clinical sciences, and he takes part in the Healthy Longevity Translational Research Program and NUH Center for Healthy Longevity. No, I got it wrong. Sorry. So basically, he's a research assistant professor and head of clinical sciences in the NUHS Center for Healthy Longevity. Sorry, my bad. So Dr. Goh is an assistant professor with the NUS Medical Healthy Longevity Translational Research Program and the Department of Physiology in Yong Loo School of Medicine. He's a principal investigator and head of exercise physiology and biomarkers laboratory, and also hold a joint research appointment with National Cancer Centre Singapore. He obtained his Bachelor of Science and Masters of Science in Exercise Science from Indiana University and Washington State University. And he has a PhD in Exercise and Cancer Biology from University of Washington. And since 2014, that's almost like 1 decade ago, he has led human performance studies varying from immune characterization of multiple days of exercise training to current study in human breast cancer rehab. So that's quite a lot of mouthful. So without further ado, I would like Dr. Goh to take away his webinar title of the role of exercise training in mediating immune and physiological outcomes in breast cancer.
Thanks very much for the kind introduction, Victor, and thanks for the invitation, Joshua and SMAS. Yeah, I think I tend to be very interested in a lot of things. I think people say that that's kind of a weakness of mine. I tend to think that I'm just interested in many things in our world. So maybe what I'll start off with is to share some of the, let me see, stats statistics are boring, but at least they give us a way of a framework. If we look at the incidence of breast cancer in Singapore, it's really the #1 cancer that affects women today. Compared to the #1 cancer for men, it's about 6,900 in men, but about 13,000 in women for breast cancer. And if we look at in terms of the incidence, it's 30%, so about 1 in 3 women develop breast cancer. And then if we look at the mortality risk itself, it's about 17.1% over here on the right. So in other words, it's also the most pressing issue if we were to talk about curing cancer or combating cancer for women. So the good news is this: we know that exercise training or regular exercise enhances many clinical outcomes, and that involves or that includes also survivorship in people with cancer. This is just a summary of different studies that looked at, it's a meta-analysis of systematic reviews. Many different studies presented the outcomes and looked at the hazard ratios of developing having survivorship in terms of exercise and the rates of survivorship in people that went for exercise training versus those that didn't. If you look at 1 being the reference group, anything less than 1 suggests an improvement in survivorship. Okay, so there's a reduction in cancer recurrence, a reduction in cancer deaths. So it's evident that this is actually a powerful effect of exercise. But the question then is always, how does it work? And we are always asking, how does exercise boost the immune system? And we see this in the lay press, all the time, and that exercise, quote unquote, boosts the immune system. But how does it do so? And I hope to share a little bit of this, or rather share a little bit of this information with you over the next couple of minutes, and kind of bring you back to about 20 years ago. So this was 2005. I was actually reading this paper. There's actually this paper in Starbucks in Barnes & Noble, so a cafe in the US, doing my graduate studies. So these leaders in our field, Mark Fabrel and Bette Peterson, they came up with a hypothesis, a working hypothesis back then, which has been shown to work. And that is this effects of contraction-induced release of this molecule called myokine. All right, so proteins or peptides that are being released from the skeletal muscle under contraction conditions. So when the muscle contracts during physical activity, during exercise. And they asked the question whether exercise, or rather whether skeletal muscle is actually an endocrine organ. So an endocrine organ essentially releases things like your hormones, your peptides, that actually have effects on distant organs, and it essentially illustrates the powerful effects of that organ. Okay, so if exercise is indeed medicine, then skeletal muscle is the harbinger of that medicine, because skeletal muscle can release these powerful factors that affects every single organ in the body. Now, if we look at the contracting skeletal muscle as a model, then we see that these myokines that are being released from skeletal muscle can affect the cardiovascular system, can affect the brain. If you look further down on the left, it can influence skeletal muscle itself, so that's an autocrine effect. It can, of course, also have this effect on cancer. So these potential myokines are being released, and it has an impact on the developing tumor. So essentially, it does this. It talks to the other organs. We think of all these different cells in our bodies having communication all the time, every single second in the time of the day. So there are these proteins, these myokines, that are called those interleukins, right? Interleukin 6, IL-6, or there's this molecule called meteorin-like protein. And then they can have effects on, as I was saying earlier, there would be other organs like adipose tissue, could have effects on the immune system. These are different players in the immune system, monocytes or macrophage, natural killer cells, and so on. And it's, in essence, govern the immune responses in the body. Okay, and also then the other organ effects are being mediated through what is being released from the skeletal muscle. But of course, the story is not as simple as just skeletal muscle. Now, what happens during even just a single session of exercise, and what we typically call in our field as acute exercise, is that up to 15,000 molecules are being released after a single session of exercise. And in this case, these researchers from Stanford University were looking at a group of runners doing a treadmill run, okay, getting blood before and after the treadmill run and showing that they could identify up to 15,000 molecules, and they include things like mRNA, their proteins, their metabolites, and even lipid molecules. So essentially, a whole host of molecules are being released after exercise. So collectively, the field has decided that since it's not just skeletal muscle being the only responsible organ that is releasing all these potentially beneficial molecules, we have decided to call them, for lack of a better word, exokines. Okay, and this was actually termed or coined by Professor Mark Tarnopolsky from McMaster University. So moving back to cancer. Now, what happens during a lot of the treatment processes, such as chemotherapy, is that there's going to be a lot of pathological cardiac remodeling, right? So there's increased fibrosis, there's going to be tissue damage, and it's been found or reported that at least 30% of women with breast cancer actually have a very low VO2 peak. Now, this is actually below 15.4 mils per kg per minute, which is actually the minimum for activities of daily living. Now, furthermore, some of these studies have shown that there's also going to be a loss of skeletal muscle mass, a condition called sarcopenia. And in women with breast cancer, this actually drives up even poorer prognosis. And notwithstanding, there's also going to be a correlation with high-grade chemotoxicity. Okay, so all bad. But at least we know that exercise can then combat each of these potential detriments: cardiotoxicity, systemic inflammation, skeletal muscle cachexia. Now, we are still talking on the role of cancer. And what we typically think of cancer is this. We think of cancer as just being this group of cells that were originally normal, and then they became transformed. They transformed to become malignant. So when they become malignant, they then spread from the original cancer site to other parts of the body in a process called metastasis. Now, what we think of is, not wrong, but in the last 15, 20 years, we now know that the cancer cell itself, just like animals in nature, they don't just exist in isolation, okay? When we think of biodiversity in nature, it's the same as in the cancer microenvironment. So within the cancer microenvironment, we are thinking of different cell types. Of course, there is the cancer cell, all right? So you have this here, the epithelial cell, which is currently growing. You have the blood vessels that innervates them, or rather perfuses them and gives them supplies, oxygen, and so on. But if you look at all these schema, you can see that there are many, many different cell types that are involved inside this cancer microenvironment or tumor microenvironment. We have what we call the tumor-associated macrophages, which are so-called big eaters or Pac-Man cells. I like to call them that. You have B cells, you have dendritic cells, you have cancer-associated fibroblasts or CAFs, you have T cells, stromal cells. Essentially, you have a whole ecosystem within the body if there's a person has cancer, and then this is actually the microenvironment or the ecosystem. So my research for over the past 15, 20 years has been focused on how does exercise then modulate or affect these guys, the tumor-associated macrophages, the Big Macs, okay, or rather the Pac-Mans. So we hypothesized back then that exercise can actually shift the killing effects of these macrophages, right? Macrophages are kind of like not just your Pac-Man, but they're also like your Swiss Army knife. They can actually take on multiple hats. They can shift from a cancer-promoting phenotype called the M2-like phenotype. Okay, they express very different molecules. They're tumor-trophic, meaning that they support cancer cell growth, or they can actually become cancer-killing, so cytotoxic macrophages, the M1-like macrophages. So then as part of our work in preclinical animal models, we then looked at transgenic mice that would actually develop cancer at a certain stage in their lives, usually very young mice. Now, these are genetically modified mice. So what we did was we actually put them on a course of in running in a cage, and we give them access to running wheels. Then what we did was we then followed them over 2 months and palpated the mammary glands. They had 8 glands. We just monitored the glands, and then after they had cancer for 2 months, we then sacrificed them and measured the tumor sizes. We probed the cancer microenvironment for signs of these tumor-associated macrophages for the M1 and the M2 phenotype. So essentially what we found was that during early cancer progression, you can see that the non-runners were in blue, the runners in orange. There was actually a decrease in the tumor sizes of the mice that ran. Now, if we look at all the 8 glands, and there are four per site on the left, on the right, you can see that there were significant decreases in the tumor sizes between the runners and the non-runners, suggesting that exercise, in the absence of any chemotherapy, there was this protective effect against slowing down cancer growth. Okay, now we have to bear in mind that these mice were not given chemotherapy. We just gave them access to 24/7 running wheels. Now, if we look at the dose-response relationship, this was also evident in the mice that ran the most compared to the mice that ran the least. In terms of, we call them high-volume runners versus low-volume runners, compared with non-runners, which are in the control group. They had much smaller tumor sizes compared to the ones in the control group. Now, what we then saw was that there were unfortunately no effects in terms of cell growth between the runners and non-runners. So this is essentially what you're seeing is a snapshot of the cancer cells themselves in the mammary gland, and then we probe them with specific cell markers that we call, well, in this case, it's Ki67. It's a marker for cell proliferation. We saw that there were no differences in terms of the intensity of the staining, in terms of the abundance of the staining. Now, when we looked at the macrophage story in these primary mammary tumors, there were also no differences in terms of the mRNA, no differences in the gene expression between M1 and M2, I mean, between the runners and the non-runners. So then, what we found, at least in this transgenic mouse model, was that there was no apparent effect on the late stage of cancer growth, but there was an early effect. If the mice were given access to the running wheels early in the cancer growth, it seemed to slow it down. But it happened in spite of the effects on the macrophage phenotype. So there were no changes at the end of the study between the M1 and the M2 mRNA expression. Okay, so now some of the challenges was that these mice were very useful as a model system, but the problem is they're young mice. And we know that cancer is essentially an age-associated disease. So, and then the thing is, we needed to find better models that replicated the aging process. Okay, we needed to have a use of better physiologically relevant models. So what we did was we then took 15 to 18-month-old mice, this time with a different model system, and then we implanted the mammary cancer, the breast cancer, into the mammary fat pad of these mice, and then continued to let them run for the next couple of weeks. So these are very old mice, so 15 to 18-month-old mice, very similar to, in human terms, about 50 to 60 years old, which is where the majority of mammary cancers are being diagnosed, especially those that are hormonally positive. So what we found was that in the mice, just as similar to the transgenic mouse model, in this mouse model, we found that there were effects in terms of the running, the amount of distance that they ran before the implant of the tumor cells. There was a correlation. So the more they ran, the smaller the tumor sizes. Okay, it was significant at the 0.01 level, and the R was actually a negative 0.9, which is quite strong. So what we also found in a very recent study that we just conducted recently in the same samples was that we found there was this increased distance ran, which correlated with the amount of, or the presence of the M1 type macrophages. Again, I remind you that the M1 type macrophages are the cancer-killing macrophages, and we saw that the more that the mice ran during the cancer progression, the more of these M1 type cancer-killing cells were evident in the primary tumor. Sorry, this is actually in the lung tumor tissue. So this is already metastasized. Okay, so when we look at then the ratios of the M1 to the M2 macrophages in the lung microenvironment, we saw that there was an increase in the M1 relative to the M2. So suggesting that the exercise that the mice were doing was shifting the identity of these macrophages to be more anti-cancer, less pro-cancer. And this was quite exciting for us. These are still unpublished results. We are planning to submit them for publication very, very soon. Now, in summary, what we found was that the old mice were suitable as a model system to test the effects of exercise and to test the effects of these kinds of tumor implants. And we also found that this volume of exercise that they ran, that these mice ran, actually had a protective effect in terms of signaling the changes in macrophages towards more of the anti-cancer M1 phenotype. Now, so if we look at this and then we say these are still preclinical animal studies, so what about the story from the human side? Okay, so this study was done by the late Pernille Højman from the University of Copenhagen. And her study has focused on this over the last couple of years, essentially showing that if you were to take blood from people that exercise, all right, whatever is happening, and if you remember what I talked about in terms of the myokine, the exokine story, that when you exercise, you release all these molecules into the blood, and it's possible that these molecules can then have this anti-cancer effect. So what they did was quite elegant. Okay, they took the women with breast cancer to exercise, and then they took the blood from them before and after exercise and applied these serum into in vitro approach. So they took the serum, applied them to cancer cells, in this case, breast cancer cells, and they found that there was this attenuation of growth. They reduced the cancer cell growth. So then if you think of this, like every subsequent exercise bout that a person with cancer does, what it then stimulates is the constant release or the acute release of these potential factors that could stimulate or rather to inhibit the tumor growth. So this is what they did in their group. Okay, now you see the MCF7, these are the hormonal positive cancer cell line, and the MDA-MB231, these are the triple negative cancer cell line, breast cancer cell line, which are notoriously difficult to treat. So what they are showing here is essentially this pre and post blood serum from the women has this effect of suppressing the growth of both types of cancer cells. Now, what they did in their studies was that they took the serum directly from the women and then applied them directly to the two cancer cell lines. Now, in our lab, what we found was this. If you take the serum directly and then you apply that to any other cell line, if you applied it to, in this case, we looked at muscle cell lines from mice, they will die. Okay, so it may or may not be the direct effects of the human serum per se. So what we have done recently, and this is again preliminary data, is that we took, and I apologize, the images look a little fuzzy here. What we did was this. We grew out these C2, C12 myotubes. These are essentially mouse muscle fibers. We grow them up in vitro, okay? We then applied human serum. So we have ourselves, we have one of our staff, she exercised, she did high intensity cycloergometry. We took her serum, we applied that to the muscle cells. We took the muscle cells after 24 hours, they released some factors into the supernatant, which is a culture medium. We took the supernatant and then we transferred them to breast cancer cells. So in other words, we allowed whatever the muscles were being exposed to by exercise human serum, we took that factor, we transferred them this time to cancer cells. Okay, we did exactly the same things, but now what we did was we took the supernatant instead of the human serum directly. And again, this is again our preliminary data, and what we can say is that if we're looking at the proliferation, this is just, it says absorbance here, but we're looking at cell proliferation. This is an index of proliferation. And what we see in these were MCF7 cancer cell lines, so the hormonal positive cell line. We saw that there was a close to significant effects of reducing cancer cell growth just by the supernatant alone. So this is quite provocative, and we are thinking that we need to repeat these experiments again to really find out what the mechanisms are in terms of killing cancer cells. Again, I need to highlight, we are seeing all these potential effects in the absence of neoadjuvant treatment. So in the absence of chemotherapy, surgery, or radiation. Again, these are all just with exercise effects alone. So if we talk about really looking at a clinical study, all right, the last 2 years, we've actually collaborated with the National Cancer Center Singapore, Singapore Cancer Society, and Genome Institute of Singapore. We looked at a 6-month combined aerobic and resistance exercise training on women with breast cancer. This was a pilot study, but we monitored the women every 8 weeks. So baseline 8 weeks, 16 and 24 weeks, we looked at the biomarkers, we looked at the muscle mass, we looked at VO2 changes, and then we looked at also some immune outcomes. And unfortunately, we kind of ran out of time, or I ran out of time today. So we only have to say that data analysis is still in progress, but we are excited to share when we are ready, probably in a couple of weeks' time, and we hope to get this published very quickly. So I'm afraid that's all the time I have for you today. What we will just say is that essentially what we want to look at is to see how, when we exercise, when we contract skeletal muscle, what are these factors that are potentially responsible for us tuning, boosting the immune system, and making them more preventative for cancer cure. I thank you very much for your time. And these people that I want to acknowledge from both the University of Washington with my PhD group, my current lab, collaborators from National Cancer Center Singapore, Healthy Longevity Program, and of course, A-Star folks from A-Star. Thank you very much.
Thank you, Jorming. Yeah, that was very thought-provoking. And I think there's quite a big research in exercise and oncology back in US. And I would love to see what are the results in Singapore. Okay, and we have our last speaker for the day. He's Mr. Etienne Ding. Mr. Etienne Ding is an exercise physiologist with more than a decade of clinical practice and experience in the private and public sectors. And he has worked in organizations such as Apple and MINDEF. He has a strong interest in health technology and youth strength conditioning. Currently, he is practicing at AMP Lab, where he is advocating a better mindset towards adopting preventive health and his unique approach to increasing health spend. So without further ado, I will let Mr. Ding take away the webinar titled Beyond the Hype, How AI is Reshaping the Role of Healthcare Practitioners. Etienne, please.
Hello, good afternoon, everyone. Hi, good afternoon, everyone. Thanks for having me in this webinar. Nice to see you all. Today, I'm going to share with you what do I do, right, in my day-to-day work as an exercise physiologist. And also, I do sport performance too. And AI has always been a trending topic. And I want to share with everybody how AI actually would be useful in our work and what are some of the implications. And then I also would like to have like thoughts from the floor. So if you find that you have been recently using AI-based tools or even AI-based software to help you in your work. So this is more of a very real-world sharing session with you all. Okay, so first, let me share a bit about myself first. I'm Etienne, and I've been practicing since, thank you for the introduction, I've been practicing since 2009 and graduated. Since I graduated, and I did a dissertation at NIE, and my topic was in motor development. So basically, it's how do we cue people, right, to understand about exercise forms, what's the amount of data that we can share with each individual, right, to make them execute a certain exercise pattern properly. So it's about communication, and that is one of my main interests at the point of time, and it's pretty useful. The research findings you can look up at NIE Library. It has helped me a lot in my practice, and I also am quite a hands-on person. I don't do as much research as I would like. Probably that's also not my strength also, and I'm quite lucky to also been given a position at NUHS in 2014. I go there and I volunteered myself at the Department of Pediatrics under Dr. Terence Lin. He's a cardiologist, and I was quite thankful. I did CPAT for youth, trying to do stress tests on them. So those with congenital heart diseases, right, whether they can return to sports safely. So I was practicing there and managing the CPAT with nurses and Dr. Terence Lim. And I'm a certified strength and conditioning coach also. So I do a fair bit of performance. Yeah, nowadays I deal mainly with non-pathological cases, and there are also pathological cases that I deal with, but it's always after the physiotherapy stage, or when the doctor refer on to the physiotherapy, then I would try to do the return to play program with them. Yes, and this is a bit of my career, so I'm pretty lucky. So I started in MINDEF. I was in the exercise and sports science department. The IPPT, the revamp of the standard obstacle course, right, was all done by my department. It was a pretty interesting project. Yeah, it was it was designed right to make sure that it fits the majority of the profile of soldiers going to try the course. So there was inputs from the ergonomists, inputs from the physiotherapy. It was a very good collaboration between everybody, and I really loved that. And then I went to work with Hui
Sorry,
Kun.
Etienne. Sorry to
Yes,
interrupt you.
yes.
I think the slides is still at the
Oh,
first
sorry,
page.
sorry.
Beyond the height.
Yes. Okay, thank you so much.
Yeah.
Yeah, then after that, I went to Football Association with Hui Kun. So we set up the Football Science and Medicine department. Yes, and then we work with national athletes to educate them on uh, what kind of rehabilitation to do, return to play program. And now we set it up and now it's still ongoing. I think it was a quite meaningful project. And then I gone to private practice. And then during the private practice, I went to Apple and we worked on Apple Watches. I was part of the research team. It was a black project. That means it's quite secretive. Nobody knew. I couldn't say like what I do there, but basically I validate the data that goes into the Apple Watches. It was quite meaningful. And throughout that whole process, right, I always have MLab ongoing. Yes, I always have projects that I'm been doing with MLab to share preventive health with the public, hosting workshop, and even working with individuals. So basically, it's what I do. A lot of on the ground practice, and I'm going to and I also give a lot of talks because this is my passion. I like to share what I do and how those research that Dr. Goh has done when it translates into real world practice, right? How it affects people, and I like to give stories to actually share with people. And people, when they hear about it, they feel like, hey, actually it works. And next part, I want like to share with you a bit more about how AI actually helps me with my work, because it's not because it's trending. It's just something that I have adopted since I work with Apple, and I have a lot of fascination with health technology. Okay, and for those who I think there's always a disconnect between what like exercise and sports science professional, exercise physiologists, strength and conditioning coach, where do they fit in exactly in this allied health practice, right? I always like to give an example when I go to the public and speak. Like this only in Singapore case, and of course there's an overlapping between, I feel like, physiotherapists. I mean, some of our job physiotherapists also can do pretty well. Like when you're injured basically at -1, right? And you go to a doctor, you go to physiotherapy, they bring you back to baseline. And then for my case, right, generally I try to build a buffer to do a +1. And that buffer, right, I want to prevent the recurrence of an injury. So that's where I usually step in. Yes. Okay. So that's what I do in a nutshell. And why I feel this topic really matters. And I welcome thoughts and opinions from the floor. So please message in the chat and I'll reply to them as soon as possible. Yes. Great. Give me a moment. So AI is really transforming the landscape because, like for my case, I don't make medical diagnosis, but more in terms like how is the patient doing in terms from this exercise program design. Am I changing his gait? Am I improving on the imbalances? I have wearables that are tracking these changes, and AI is helping me to collate the results and make it and do a visual representation of the results. And I can make my decision. Do I need to change the program? Is it working? Oh, this program is working. How long should this exercise program is working. How long should I prolong it for? Yeah. So that's one, right? Client engagement. AI is helping me to create visual data, visual representation of the data. I will show it to the client. So it's very good. And it helps the practitioner to save time and also to really engage the client better. So having said that, some of the times when I discuss with other exercise physiologists, right, they do think that, oh, is AI going to replace what I'm doing now? Is it going to be able to make a diagnosis, right? I can give you a story. One of my clients recently, he was feeling dizzy and he decided to use ChatGPT to find out. He visited a healthcare practitioner and he felt that the diagnosis wasn't accurate. So he talked to the ChatGPT, and the ChatGPT he felt gave him a better diagnosis, and it worked. So will that really disrupt us? Yeah, I would like to hear your thoughts also. And also AI helps to streamline workflows. So it helps to maybe from the execution of the program to the data collection and even to the reporting, right? If I feed it into a AI machine, it can just do that for me. And basically, if you are working in a private practice, if you have such a platform, it improves the client experience. And I think it's not only about revenue, it's about helping the patient understand, hey, actually, this practice is going to help me in my health. I understand a bit more about my health, I understand a bit more about my preventive health. Okay, then a lot of us will ask, what exactly is AI? AI, there's a few. I don't study AI, but I'm really interested. So I go and consult AI experts. I ask them a bit more about what is this exactly. There's low level AI and there's high level AI. Like ChatGPT is generally high level because it mimics human intelligence, and AI is just a broad umbrella that encompasses machine learning. Computer vision. Computer vision means it can recognize pictures. It can tell you, for example, the X-ray, where is the tear in the meniscus. And NLP, give me a moment. NLP would be natural language processing. It understands and can generate, for example, if I talk to it, it can produce something that is more human-like, even like in reporting form. So it seems more genuine. And the last one, generative AI, it can create new content. It's either you feed it data, it can generate a whole new content, tables, and all this. So generative AI encompasses all this, and it's basically, right, a few things add together. It's math, data, and logic. You need all these three components, right, for an AI machine to work. Okay, and then we thought about, okay, so now we understand AI. How does it actually apply in allied health? So there are a few things, right? Actually, one of the most important thing that I want to talk about will be 4-risk prediction from wearable data. Not that I previously worked in Apple, but because I believe I work inside and I know the amount of work that I've gone through to make sure that the data are validated and is reliable. Still, it's not a final. You still must consult with an allied health practitioner with the data to further support the case. It's not ultimatum. Yeah, but I feel that it's a good enough gauge for us to track patient progress. Okay. So I'm going to give a few examples on exactly 4-risk prediction later on. You can see, and I hope it interests you to go and find out a bit more about that. Yeah, so functional movement screening, wearable integration, gait recovery trends. Yeah, these are things that AI can actually help exercise physiologists like us who is working on the ground with clients, right, to provide better client outcome and also better client experience. It keeps them motivated to understand that they're actually improving, because some of this data analysis, right, it takes a lot. And I think we can all agree in allied health, we are all, the workload is pretty heavy because due to the amount of clients that we see, the workload. Okay, so the case study that I want to show you about the predictive fall screening, right, it's actually right at our pump. It's Apple Health Walking Steadiness. Has anyone used this feature before? Is there anyone in the audience that has used this? The good thing about this is it's very cheap. You can, an iPhone 8 basically will be able to do it, and everybody has the phone in the pocket. That's all you need. Yeah, so it's very, very interesting. Okay, so I use this to work with one of my clients with Parkinson's disease for the last 2 years. And from there, they have only 3 matrix. Okay, the 3 matrix basically is very low, low, and okay. That's it. It's super easy visual representation of the data. So very low and low, right? Based on Apple's criteria, it's your experience. You might have a risk of a fall, right, in the next 12 months, which is something I don't want, right? So, and it measures on gait, number one. The gait, it decides whether you are walking well. Number one is your step stride length. Double support time, how much time you spend on the ground with both feet, because generally walk is 1, 2, 3, 4, right? And walking symmetry, whether there's an imbalance in your hips when you shift. So based on that, it can understand, and also walking speed. The AI will create, will process the data and come up with just these 3 simple matrix: very low, low, and okay. So this you can see it's exactly the data from my client's phone. Every session, we'll check in and see how is he doing based on the exercise program. From 2023, that is January, J is January, and you can see it's all, it's the whole year of progress. So you can see it slowly changes. And this with exercise intervention on our part. Yeah. So when we show him there, he gets very motivated. He said, hey, actually all the hard work that I put in is actually turning into results. And based on that, right, you can also see it affects his quality of life because he's actually a very active person, right? Before the onset of this disease. And after he started the rehabilitation process, you can see he started moving a bit more. And of course, it's a snowballing thing, right? He started moving a bit more, he gets a bit healthier. And with Parkinson's disease, generally, you want muscle fitness because it helps with the control of the posture, it helps with the control of the gait. Yeah, you can see his daily average steps is improving since 2023 January. Yeah, so this is what AI does. It creates that trend line for me. It helps me a lot with my work. And I'll show you a video of how he changes over time. So this is him in 2023. You can see. So, and now this is at Bedok Stadium. Yeah. So I mean, the exercise prescription, I feel it's quite standardized. It's how you tailor the exercise prescription to each individual. But with AI helping me to analyze the outcome of the exercise program and create this trend line, I can very much easily understand what can I do to change. So that's one. And also, give me a moment. And then after that, so once it progress, right, then I can start to understand, oh, is there a plateau in the progress? And then we bring him to different terrain. So this is what I do day to day. I change the exercise variety, and also I put in BlazePod is one of the things they have. It's low level AI. Basically, they collect data and then they compare with other people and they can tell you just it's good, bad, where you are at average. Yeah. So ultimately, at our clinic, generally we have two goal settings with them. So this is the outcome of using a good rehabilitation. He can go on and improve his quality of living, like activities of daily living. We have always at the tip of our tongue, right? Yeah, this is actually the quality of life and activity of daily living. And then there's a second case study. This is which talks about AI, like Whoop. Has anyone used Whoop before or Garmin? Those who are runners, basically you have a variable where it takes your height, HRV, your sleep, and then it tells you how much how much training strain you have. And then you can know, okay, whether you should have a recovery day, whether you can push a bit more, how much to push. Yeah. So this is another usage of AI in helping me to understand how to train my client during the rehabilitation process. The second case study, right, it's to do with a quadruple bypass. He had a quadruple bypass. He was an active cyclist before. And the prognosis for him, oh, what will you say are key qualities? Okay, Zikang, right, later on, thanks for the question. Later on, I can help to answer. So this was in the beginning. Yeah, we were doing the step test. Yeah, we have to have a blood pressure monitor on him to make sure that everything is within norms. Yes, so this was same beginning after a quadruple bypass. And the prognosis was same basically to the outcome for him, right, even after the surgery was just to cycle on the PCN, but he was a avid cyclist, cycling 100 km almost like every week, sorry. So my goal is to bring him back to it. So we set up a plan. Okay, this is our cardiac rehabilitation for 26 weeks. Where are we going to do it? And it's evidence-based. We look it up and we see what we could do. And because thanks to AI, right, I could exactly understand from his hardware what went wrong, what do I need to collect. Because the graph was from his left femoral artery, and basically the left leg has muscle loss. So I want to balance it out. AI helped me to visualize the data. I can understand that his left side is overcompensating on the right because the left has no muscular strength. So what kind of adjustment do I need to make to the rehabilitation program? Because there's a limit to how much, what is the capability of his cardiorespiratory system. And the only thing that I can do, right, is to improve his muscular fitness to compensate for the lack of that, because he's on some medication and there's a limit to his maximum heart rate. So we corrected that. And then also this is it's a lot of data to take in, but if you are used to using it, you can basically see on the top there's 7.8, 7.1. Those are AI generated figure to tell me how much stress, right, is the person having after the activity. And then on the last picture, you can see, right, it actually tells you how much recovery that you have gone through already. Are you fully recovered for the next part of activity? So with that, we can safely program his exercise program and make sure that he doesn't overstretch himself, because he's still a survivor of a quadruple bypass, right? Yeah. And using Training Peaks also helped me to understand, okay, we have this program, his fitness, his fatigue, and you can see on the right-hand side, this is a matrix from Training Peak. The form, if it's the negative, means it's overtraining. And then we should try to pull it back and do adjustments to it. So these are things that AI actually was quite helpful for us, right, to sort of give us another view of how can we adjust the program, because otherwise the more opinion it is, but ultimately it will come to the practitioner himself, right, to make to have a good clinical reasoning of the output by the AI, because sometimes I feel it's still not fully ready yet. So you still need to have that good clinical reasoning. And this is the outcome. So this is after 1 year and 1 month of rehabilitation. He finished 130 km. This was a race in Bali and 1,865 meters of elevation. To put things in perspective, that's about 100 plus, 10, about 12 Mount Faber. Yeah. So yeah, so this is what I feel the field of exercise physiologists, right, can do, is to help people go to +1, enjoy a quality of living. Yes. And that's what I also enjoy doing. I feel it's quite meaningful. Okay. And after that, the conversation, right? So the benefits I summarize again, is really time efficiency. It helps me to collate the data, visualize the data so that I can make a decision. What should be the next step I can take to help to improve patient outcome. It's objective, the data are repeatable. And lastly, client engagement, because I have reports to show them and it's churned out so quickly. There are limitations. The most important limitation I feel of over reliance on AI is you switch off, you trust AI too much at sometimes because you need to still have good clinical reasoning as a practitioner, and that comes from a lot of ground practice, right? Yeah, so we just need to be mindful of that. And of course, data privacy concerns. So like Apple is so that's why I trust Apple a lot, because Apple basically, they don't sell the data, and things that we use are HIPAA actually. And that comes to the end of my presentation. Maybe from the floor, do you have any AI tools that you have used to help in your practice, especially those that are doing a lot of ground practice? And where do you see the biggest risk?